I appreciate your interest in the topic because it's been an ongoing struggle in our county and region for, since I've been practicing, which is 20 years now. And unfortunately, it just never seems to get momentum towards improvement. And I would say that's also true, as you mentioned, with my other colleagues in different specialties like primary care. I would say for sure pediatrics is up there in that list, and also mental health care. These are all really significant deficits for us. And it's a struggle routinely to get people access to the people they need to get them comprehensive care. I think some of it stems from the geography of our region. We are essentially an island and don't really have the access to the population of the metro area for Seattle, Tacoma that I think would normally be available if we were contiguous with them. And so to attract people to come work out here, it's a challenge to recruit providers to the area. So many of us are homegrown, love this place and want to live and work and raise our kids here. And trying to find people to come join us is an ongoing issue. Once they get here, I think most people really love it and want to stay. But I think there's a number of reasons that is problematic for all of those specialties. And one of the biggest drivers is economics, in the sense that we get paid a whole lot less than people who work in metro areas do. So when you're looking at competitive salaries for an obstetrician gynecologist or an internist or a pediatrician or a family practice provider, they have more competitive wage options in metro areas. And you see that throughout the state. I know that you said that we're one of the lowest. I would say that we are one of the lowest, but probably not the lowest. There are certainly counties in the state that don't have any obstetrician gynecologists, and we refer to those places as maternal health care deserts because they just don't have anyone to provide maternity care or delivery services for people. But when you look at the population density that we have and the increase in the population that we're expecting, it's pretty scary, actually. And it definitely impacts our ability to provide access to everybody. So one of the things that has recently sort of made this a highlight, and one of the things that sort of drove me to present at the county health board, was the closure of the naval facility for obstetrics. As all of you probably know, there's been a gradual wind down of healthcare services for our military service members and their dependents. The Naval Hospital is pretty much a shell at this point, and they provide only outpatient services for clinic. But when they closed, that effectively reduced our obstetrics provider pool by about half. That we didn't have very good contact and communications with that group, but there were at any time about 4 OBGYNs and probably 4 to 6 certified nurse midwives serving that population. And when they closed, that obviously went away, as did their labor and delivery and maternity services. And those patients have all been basically offloaded onto the remaining OBGYN and pregnancy providers in the community. That decision was not particularly transparent. Apparently, they did an estimate on the local regional providers and found that there was a, quote, adequate amount of community civilian healthcare providers to absorb those patients. And obviously, they didn't look at the geography because nobody wants to take a ferry to go have your baby. And the next closest places that actually do delivery services are Tacoma, really, for any large labor and delivery. Jefferson Hospital does some, but not much. So we're sort of the main delivery center here in the Kitsap County, Kitsap Peninsula area. Anyway, so the influx of those patients plus Peninsula Community Health Clinic, they did have an OBGYN clinic with 3 providers, and they closed that practice about the same time. So it kind of was a perfect storm of an influx of patients needing urgent care, because you can't really defer pregnancy care, on an already burdened provider staff. And that resulted in us having to limit our appointment opportunities for, general routine gynecologic care, problem-based visits. And at one point, we actually stopped seeing new patients because we just didn't have the bandwidth to take care of them. New gynecologic patients. We were seeing patients for cancers and urgent surgical issues. But, if you called to schedule your annual exam, we would say, well, we'll probably see you in about 6 to 9 months, because there just isn't any place to put people. So that basically robbed, the rest of my, our focus, which is not only maternity care and delivery, but women's health care. And the women's health care side of things really got put on the back burner. And that's a sad state of affairs, because we have certainly skilled people here who can provide that care. We just don't have enough of them. So that's kind of the current situation in a nutshell. And I've been in discussion with, the health department and trying to figure out ways to make this a more attractive area. Mr. Gelder with the Public Health District Hospital, I think, is, an exceptional potential for us if we can have other employment situations and other locations to provide care aside from our single entity in the community. That might make it a more attractive place as well.
I have a couple of questions, and I'm sure others will have questions as well. One of mine is directly related to, a little teeny piece of background here. I moved out here full-time in 2016. We lived in Yakima for 32 years, where my husband was a neonatologist. He's now retired. So one of the interesting things that we discovered there is, well, first of all, there were a lot of OBs when we came to Yakima, because it was the health center for the Yakima County. And that was really great. But as they retired, we noticed that they weren't all replaced. So I think that is an issue. But with the Navy's closing, I think in particular, it's a similar kind of scenario where you've got one particular group that is, when it goes away, it goes away. Its absence is immediately noticed. And I guess that one of the things that happened there, and I don't know if you know this, the answer to this question, and that is, are there any significant number of family practice doctors doing OB, or more importantly, women's health GYN care? Because there were a lot in Yakima, and I'm not sure there are many here.
Yeah. Well, that's a great question. And I would say your observation that the challenge of finding replacement providers for people retiring, that's a nationwide problem. And it has to do, I think, a lot with the nature of the job that we do. Obstetricians we have crazy hours. We work all the time, 24/7, 365. And we also have a high risk environment. We're taking care of 2 patients at once. And generally these patients are healthy, normal people with very low risk histories. But in obstetrics, things can go wrong in a hurry. And so people who are otherwise normal and healthy with anticipated good outcomes can sometimes have very devastating outcomes with injuries to moms and babies and deaths to moms and babies. And that is unavoidable. Having a baby is one of the most risky things a woman will ever do in her lifetime. And our job is to try to mitigate that risk, but we can't eliminate that risk. And over the years, American healthcare is an incredibly litigious environment. And OBs definitely have one of the highest lawsuit rates, and we pay the highest malpractice insurances of most providers across the board. I think our, estimates of our local malpractice rates range from $40,000 a year to $150,000 a year. And that's just basically buying your tickets so you can practice. So that's already put you in the hole for that amount of money before you're even making money to pay for that cost and to pay for your overhead and to pay for, running a practice. So bottom line, and the other side is that OBGYNs, if you look compared to other surgical specialties across the board, so comparing us to folks like the male equivalent would be a urologist, we get paid a fraction of what they get paid. So our reimbursement from a surgical specialty perspective is woefully inadequate for what we're doing. And those combinations, the poor salary reimbursements, the high risk environment, and the high cost to just actually have the privilege of practicing really is a detractor. There are not that many people who want to enter this field because of those reasons. So say you're a medical student looking at going into residency for any subspecialty training, and you would say, well, I could have crazy hours and be up all night delivering babies twice a week and working 12-hour-a-day shifts and making half as much money as a urologist would, who doesn't take call at nighttime very often and who doesn't face those, litigious environments. And it's an easy choice. I mean, I don't think very many people are really interested in pursuing this type of healthcare, which is sad because it's a wonderful job. I mean, I think those of us who are in it are here because we love what we do. And if I had to go back and look at different courses of jobs, I'd probably still pick this, but probably with hindsight and clearer eyes that it isn't an easy road. Yeah. And it's American healthcare is also pretty interesting to, in a sick kind of way, and that it's all become consolidated and corporate. So when your husband probably entered as a neonatologist, there were certainly wide ranges of employment opportunities, from being a private practice person where you're basically running your own business to joining a group of multi-specialty group where you're still a private entity, but you have sort of a bigger base of lots of different types of providers funneling into that business entity. And then there's employed physicians who are, work for these sort of more corporate entities like our Franciscans or Virginia Masons or Swedish or CHI. Over the past decade, everything has basically been absorbed by these large corporate entities. And, regionally, we have, it's called Virginia Mason Franciscan Medical Group. And I think they put that label on it to make it seem like it was still a Northwest entity, but it's really owned by Common Spirit Health, which is a nationwide entity that is basically a large Catholic health group that has gobbled up most of the practices in the region. So almost everybody works for them in this county. There are very few people who don't work for that financial entity left. And that is from my perspective we still have a private practice in the group that I work with. And it's interesting because we don't get paid very much, we are in fact not very attractive to those large corporations, because we would actually be costing them money in terms of paying for malpractice and paying for the overhead and support and things that are expected for maternity care. And with the reimbursements that we get back, I mean, we barely break even at this point. So we've pretty much flown under the radar for being consumed by CHI Franciscan, because we're not an attractive addition to their pie. And that's interesting. It's not just them. Like, we as a practice have looked at other ways to try to maintain our independence in our business. And some of the more modern options would be to try to join a group of specialty practices to basically buffer it out, so that you're supporting each other and you have collective purchasing power, so you can purchase your equipment at lower rates, because the bigger you are, the bigger bundle you can buy, and the cheaper each of those individual parts will be. And the same thing is actually true with trying to negotiate reimbursement from our insurance providers. So the smaller the group, the less they're going to pay you. The bigger the group, the more you get paid. So if you say compared what I make for a pregnancy care to what, say, a Franciscan medical group obstetrician gets for pregnancy care, those are vastly different numbers, because they have a bigger negotiating power with those insurance providers, and they can say, okay, this is what we're going to accept as a payment for this service. On the other hand, we get told what we're going to get paid for a service, because we just don't have that level of negotiating power. So anyway, our practice had looked at some varying options to try to join some of these groups. And again, we were rebuffed because we don't make anybody any money. And so it's not of a financial benefit for them to incorporate, women's health care in their business model, because we are a potential drag on their system and not somebody who's actually contributing or providing profit for them.
Well, thank you. I know a little bit about that from my husband's experience, so I can totally relate to that. I want to get to a couple of questions here. Betsy, you want to go first?
Sure. Thank you. And thank you very much for this presentation. It's been very illuminating. There is a process going on right now in the county. Their comp plan is being updated for their periodic update. And I wondered if there is any component of sort of land use, and or if you can think of anything.
Betsy, put out there for a minute. I couldn't catch that.
Okay, sorry. I'm wondering if you can think of any components that we should be raising to the county, either countywide or frankly for North Kitsap and Kingston. I was thinking about the idea that in reality, we should be encouraging zoning and other practices that would increase our healthcare providers. So I'm just thinking, are there any barriers that you can think of from a sort of land use, zoning, or other kind of incentive structure that we should be bringing to the county about this, about improving the opportunity for healthcare providers, and particularly, women's health providers?
Oh, that's a good question. I have to say that
That's the question.
I don't have much knowledge in the zoning world. I would say that probably not. Unless it's zoning for acts, building medical facilities. Our clinic spaces we have a surplus of them now, actually. With the closure of the Bremerton area, there's lots of clinic space available for fairly inexpensive rent. It's sort of more remote from the inpatient services here in Silverdale. But finding clinic space up in North Kitsap or towards, Bainbridge area, it's doable, but I don't think there's a lack of the opportunity to set up a medical practice. It's more a cost thing. And again, that comes back to, how do you want to deliver that care? If it's part of some of these big corporate entities, they of course have big pockets and can put their facility wherever they want to. But a private practice like mine, it's pretty tough to find cheap real estate for that. So I'm not sure if there's zoning that could, I don't know enough about it, but the square footage rent for us, it's a big issue. We have a satellite office up in Paulsbo, but it's pretty old and dingy, and it's cheap, and that's why we're there, because when we looked at other places to expand to, those were challenging. They wouldn't fit into our economics.
Okay. Well, that's helpful. That's an interesting topic. Just the idea of incentivizing this use in certain buildings is something I appreciate you giving me that idea. I'll work with that. Thank you.
Okay, Pat, you have a question.
Yes, I do. I was wondering if you had in mind, if you could rule the world, or at least Kitsap County, what solutions could you think of that would really help, especially your area of expertise, but all bringing in the doctors that are so deficient all over Kitsap County?
Well, I think, recruiting a younger population would be lovely. That whole replacing the people that are going to retire. Sadly, if you look at those of us in OBGYN, the ones who are left standing, 3/4 of us are over 50 right now. So in the next 10 years, I would expect many of us to be looking towards retirement. And if we can't replace them, then that's going to be very painful. I'm over 50, and I've been, looking at retirement planning and when and how am I going to do that. But one of the things that is the hugest challenge is I don't want to leave my colleagues high and dry. We have this enormous volume of patients. And if I just say, oh, I'm retiring in 2 years, good luck finding somebody, that is, that's not okay. And so we have to try to come up with an exit strategy for that. I think that historically, hiring people was, when a private practice brings somebody on, we basically subsidize their development as a provider for about 2 years before they're actually making profit and covering their own costs. And so that's a huge cost to those of us who are trying to subsidize those new onboarding new people. And that's a real limiting factor in terms of us being able to do, say, more than one at a time. And at some times in the last, I'd say, 5 to 10 years, there were periods of time where we wouldn't have been able to afford to do that. The corporate side of things, they of course have bigger pockets to be able to get through those 2 years. They also have hiring incentives, so they can reimburse student loans if they so choose. They can provide relocation bonuses. So there's different ways that they can be appealing to attracting new providers. I would love to have our county be designated a critical access to care site that, and figure out how to reword some of our federal funding to be able to attract new providers with student loan repayments. I think that would be enormous, and not have that tied to a particular employer. So that could be whether you joined private Kitsap OB/GYN, or whether you went to work for the tribe, or whether you went to work for a CHI Franciscan, that you could somehow tie into some federal reimbursement for your student loans. That is how places that have limited access to providers attract those people. Oftentimes it's only for a few years, but at least they have sort of a steady supply of new graduating providers that are anxious to get rid of their hundreds of thousands of dollars of student loans and are willing to basically work for that repayment cost. Those monies are only available for certain medical institutions right now, like the public health clinics. So the Peninsula Community Health Center is designated a public health clinic, and they meet certain criteria for being able to access those funds. So if somebody went to work for a Peninsula Community Health Clinic, they could offer student loan reimbursement for that provider. To be one of those public health access locations, there's very specific criteria for that. We looked into that option too. You have to be a primary care office, and you have to have a certain level of Medicare, Medicaid clientele. You have to actually apply to the funding program, and that would be competing with any other public health clinic that currently exists. So if I were magically to be able to make Kitsap OB one of these public health designated sites, I'm competing against Peninsula Community Health Clinic to get those funds. And that seems like a limiting roadblock to us. If there was some way to say, okay, we just don't have enough doctors of all types in Kitsap County, let's figure out a way for either the state or the feds to give us some incentive pool of money to be able to help those providers establish themselves in a community and help them pay for their onboarding in that community, pay for or assist in paying for their student loan reimbursements. I think it would be huge. I mean, just the student loan thing alone would be an incredibly attractive thing. But right now, those laws are written both federally and state. And hey, as the League of Women Voters, you guys can lobby for some sort of change. And I've talked with the health department about that. And those are tough things to navigate. I mean, it's law, so you have to change law at the state level.
Do you think that having a universal healthcare system might be more helpful? And
100%. I mean, that's pie in the sky stuff. Like if we could have a single payer system that everyone had access to care, and we all got, a reasonable salary, and there was, tort reform and protection against being sued, so that, they would take my business and take my house. I mean, that happens to people, and especially OB/GYNs. And so it's if you operated in a system like that, oh my gosh, yeah. But that's, national stuff, and good golly, that's good luck there. I mean, we can try, we can dream. We were close at one point, but yeah, I don't know about now.
Do you think it might be easier at the state level rather than the national?
I think Washington, being as progressive as it is probably more likely to do that. Yeah, I mean, I don't know that we could necessarily provide a a state healthcare system, but Washington State could certainly, I think they could rewrite some rules to make that more likely.
Mhm. Yeah, let me jump in there, Kathy. Thank you very much for answering that piece, because it's really important. And there actually is a growing out of a study on universal health care. There is a state commission looking into this. And this is one of these things. I know I'm one of these crazy league advocates who this time of year, I live and breathe legislative activity. I actually even watch a lot of the videos. But there is an active process afoot investigating what could Washington State do within this wonderful federal system with all these laws at the federal level. What could we do to make universal health care more available in Washington State? So if you're interested in that, anyone, let me know, because I have contacts in that group. I used to attend the meetings, but there is a really very, very active community, which includes a number of league members who are working on what are the options for creating a variation of universal health care here in Washington State. But I wanted to move on to one more question. I hope we're not taking up too much of your time. This is so interesting. Somebody asked in the chat if you encounter barriers using the hospital facilities. I hope the answer is no, but
no, we don't. I mean, I would say that there's, I mean, the affiliations and mergers that have happened over the last 15 years have certainly changed the way our hospital operates. But there's certainly a core group of providers and community members that demand that remain a secular institution, and that we are not lumped under the Catholic Healthcare Initiative. And so at this point, there really are very few limitations in terms of what we can offer for women's reproductive health care. We can deliver babies, we can do sterilizations. I'd say the one limiting factor is termination of pregnancy. And that has been, that existed before Harrison merged with the Catholics. So that's sort of more of a conservative community standard that's a really hard thing to combat. So it's, I would say that my ability to do the things that I need to do for people really hasn't changed over the last 20 years.
That's encouraging.
Yeah.
There may be other questions, but one that I have that's kind of specific. You talked a lot about I think the term is the payer mix, how you get paid. Just off the top of your head, what roughly is your insurance versus Medicaid?
That's a great question. Well, again, I love that I live in progressive Washington State, because we have for decades made sure that pregnant women get access to care. So our state healthcare system through the Medicaid branch, it doesn't take much for a woman to qualify for Molina or CHPW or United Healthcare programs for them to have insurance to cover their prenatal care and their postnatal care. It'd be nice to see that just expanded, but that's the whole universal healthcare strategy. But there are very few people that fall in the cracks where they make too much money to qualify for those state programs, and are having to pay more out of pocket for that. And of course, the Affordable Care Act kind of helped cover that little group of people. So it's really rare for me to have a pregnant woman who does not have the ability to get healthcare insurance. That being said, I would say more than 50% of my pregnant patients are state insured, which means that that's on the very low end of the payer scale. General OBGYN side of things, I would say, is It's a little different. I'd say more like 40-60. But with the closure of the Navy facility, we have, of course, had an enormous percentage of TRICARE insured patients, and they are basically equivalent to the Medicaid rates. So we don't get paid much for them either. Yeah. And, that, brings up a topic of, universal healthcare and reimbursement for physicians and making it attractive for people to come here. And again, this is not just a unique Kitsap or Washington State problem. It's a nationwide problem, is that these insurance providers they're holding us hostage in terms of how we can grow and advance, and are really driving the payments of things. And it's fascinating to me as a small business owner to watch my premiums increase every year, buying insurance for myself and my employees, and watching my reimbursement from that same provider decrease every year, or stay the same. So, I mean, for instance, Regents, which is a commercial insurer, they have refused to discuss negotiation of increased reimbursement for us for the last 5 years. So we contact them routinely saying, okay, here's our contract. We'd like to reimburse. We discuss, renegotiation. Our cost of living and cost of doing business has increased 5% over the last year, inflation, what have you. And our payments have stayed the same. And we are too small for them to care. And so they don't even bother calling us back. We have a contract attorney that we hired to assist with that, and they don't even talk to the attorney either. So interestingly enough, I contacted the insurance commissioner's office to say, hey, what gives? This is a challenge for us. And who oversees that scenario where you have it's a very strange economic situation where you have a product, which is your insurance, that the community has to purchase to get the product, which is healthcare, and there to be no communication between those two pieces. And that insurance product is really driving how we function and operate and provide care. Basically saying, okay, we're going to pay you X amount of dollars to do this job. Even if it costs more to do the job, that's all you get paid. Mm-hmm. And there's no overseeing body. The insurance commissioner was like, well, there's nobody to talk to with that. I was like, okay. Again, we're just kind of held hostage with whether or not they'll even discuss it with us.
Yeah. That's what I suspected. Thank you.
Yeah.
Unfortunately, Becky.
I'm in South Kitsap. I actually live in Manchester,
Mm-hmm.
where it's equal distant to Silverdale and to Gig Harbor and to St. Anthony's.
Mm-hmm.
Most of my friends go to St. Anthony's, and most of the people I know in Port Orchard go to St. Anthony's.
Yep. St. Anthony's is part of the medical group. Yeah. And from, just from a women's healthcare perspective, there are no obstetric services at St. Anthony's.
Okay.
So the next closest labor and delivery is at St. Joseph's in Tacoma in that system. Mm-hmm. They have a few gynecologists at the St. Anthony's hospital area, but they only do gynecology care. There's no pregnancy care there.
No pregnancy.
Yeah.
But I was just pointing out that from Port Orchard, it's most people go to St. Anthony's.
Yeah, no. And I frankly would too, if I lived down there, knowing what kind of a cluster it's been up at St. Michael's. Yeah.
Yes, it has been.
Mm-hmm.
I used to go to Harrison, but when it moved.
Yeah. No, I wouldn't either.
Mhm.
Well, and it's even harder with the other traffic issues that you have for emergency stuff in
For
particular.
sure.
Right.
Yeah.
It depends on the time of day of your emergency. You know, you don't want to go through Gorst at certain times of the day. That's
No
crazy.
kidding.
I'm sorry. It should not
Well,
be.
and when the ambulance comes for people, they always ask, which hospital do you want to go to?
If
Because
it's distant, yes, they probably would do that.
Mhm.
You know, if there's a discrepancy in difference, and they're required to take you to the closest facility that provides the care that you need. In my world with OB, that's either
Right.
how close are you to St. Joe's or to St. Michael's, but for other stuff, yeah, like if you were
right.
cardiac issue, yeah, whoever's close.
Yeah. There may be other questions. I'm not seeing any hands right now. One question that comes up to me, I'm hearing a number of policy related things. The league is I'm not unique. There are other league members like me who spend a lot of their time doing advocacy all the time. In
Mhm.
Washington state, it tends to be focused in January, February, March, and this
Mhm.
year into April. But I guess what I'm saying is that I'm hearing a couple of things that I find attractive, and I will certainly look into the critical access to care designation, because I know for a fact that we have a bill that probably will make it through this year that's giving an extra payment to those rural hospitals for critical whatever,
Mhm.
because they have such a low rate of that payer mix,
Yeah,
where you get less insurance,
yeah.
and more Medicaid. So I'm very intrigued by that idea. I'm sure it's complicated, but
I'm intrigued by that idea too. My issue with that is that all of these things historically have been hospital based. They'll say, okay, the monies are going to go to this rural hospital because that's sort of the centralized area where the care is organized and distributed. And when we were formerly Harrison, a community hospital, that probably would have been a reasonable thing, because we, as say, private providers, could work with our hospital to try to get access to those funds and access to that support, help with recruitment for providers. But if that money goes to St. Michael's, we're never going to see it. So I think that bill sounds amazing, and I think the idea of having that there, but we are such a weird situation where we just have this single hospital entity that is governed by these corporate medical. I'm sorry, I have strong opinions about them. But I just fear that, they would love that. They would just eat it up to get extra money and be labeled this critical access to care hospital. And who knows what they would use that money for.
Which is one of the reasons why most of the money in this particular bill that I'm thinking of, and I can't remember the number, goes to public hospital districts.
Great. We need
another one of those things we're looking into.
Yeah.
And as you all know, public hospital districts can create certain kinds of urgent care type facilities. There's some that have only EMT services. There's some that provide long-term care facilities. And the really interesting thing to me is I'm wondering if there could be a women's health center developed here with public hospital district funding, because this problem is not going to go away, and there are going to need to be some other opportunities for the payer mix is not going to change as long as the kind of healthcare we have in the United States.
No.
Was there another question? I thought I saw a hand for a minute, but I'm missing it now. Anybody else?
But you came up with it. I was going to ask about the public hospital district, but it would be nice to get Kathy's input on that. If that's would that help your practice?
I think it would, for sure. And having two venues to provide care. I think not only for obstetrics, but for the other aspects of healthcare, emergency care, inpatient care, surgical care. I mean, there's no competition in this community at all. And that is not a great place to be. I mean, there's no pressure on St. Michael's to provide quality care and efficient care, aside from the economic drivers that they want. Like, they don't have to worry about market share in terms of who's going to choose to go there versus someplace else, because there really is no other option for people who live in this area aside from St. Anthony's. And that's the same system. So they're not really losing anything if someone goes to St. Anthony's. So I do think that a public health hospital or a public district hospital would be excellent, because, you know, people could choose to go there instead if they wanted to, and that would presumably drive the corporates to up their game and provide a better product, back and forth between each other. And frankly, from a women's healthcare standpoint, again, we have always sort of flown under the radar and been kind of an add-on in that corporate system, because again, we don't make them any money, so they could care less about what we do. We did not get an upgrade. We have the same facility that we've had for 25 years. When they built this fancy new building, they did not remodel or improve our labor and delivery or operating rooms or anything. They're just like, oh, we're building this new hospital, you can stay right over there.
Yeah.
Which is interesting, you know. And as you said, our payer mix is really heavily public health payment issues. So, you know, if we could have a facility that was driven towards, you know, the care of women, you know, more than 50% of people have public health insurance who are seeking maternity health care. And if we had a center that was really designed to service those patients, without having sort of being an afterthought, that'd be great. I'd love it.
You think increased scholarships at our, I think we have 2 medical colleges in Washington State, at the University of Washington and Eastern.
And in
part-
Eastern, yeah,
Yeah.
no, I'm a graduate of the UW. I did both my medical school and residency training there. Yeah.
So if increased scholarships there might help too, if designated for women's health, because we
Yeah.
are really underserved.
Yeah, no, you know, certainly the residency training program there, there's only 6 slots per year at the Seattle campus. I don't, and it's a medical school at the Pullman campus. So that's, you know, general medical training. But when you're training specialists, that's after you graduate from med school and go to residency. There's the UW program, and Swedish started a program, I think, I want to say 5 years ago. So I think they have 4. I'm not entirely sure. So they have, you know, up to the number of OBs being produced yearly, but certainly not enough to match the growing population.
Mhm.
Yeah. And, you know, I'm sure the residency programs would love extra money to fund another spot. That'd be great.
Mhm.
I
If
think
that
we
could
probably
provide-
agree very much on the universal health care or something, public funded health care for everybody. And so I was just wondering if we could do it at the state level independently, because that's going to be a long, long fight to get it into the national, national health care. I think maybe it'll go faster than I think it will, but you never know.
You never know. Yeah.
Yeah.
I guess the final question is Pat asked earlier if you could wave a magic wand and change the healthcare system. I think we have some answers to that. If there were 2 or 3 things that you would like us to do as we pursue our advocacy locally, that
Sure.
would be great.
They pressure the insurance commissioner in some way to investigate the reimbursement issue. I'm not sure how. I mean, as I said, I've reached out and contacted them, and their response was, "Well, that's interesting. I'll look into it." And of course, don't hear back from them. The other person I reached out to was the medical director for Medicaid at the state level on the Washington State Health Board. I can't remember what her name is off the top of my head. But to have Washington State Medicare, Medicaid increase their reimbursement for women's healthcare services would be enormous. I mean, even if it was like a 3% increase in reimbursements for us, because there's such a huge percentage of our payer mix, that would make a big, big difference. And that could go through on a state legislative level. Like there could be something that says, oh, wow, look at these women's healthcare fees are substandard. We need to boost them up. And that would not only help us locally, but other areas that also have these maternal healthcare deserts where there are other counties, like Grays County, oh my gosh, there's nobody out there. And places in northeastern Washington where there's nobody out there either. It's, if you could actually run a practice with a majority state funded insurance reimbursement and sustain yourself and survive, that would be huge. So if there's any way you guys can pressure the state to pay us better, that would be great. I think the other thing is the recruitment aspect. I mean, that's curious question that you had about, scholarships and making it attractive. And I would say going back to that student loan reimbursement thing is a big deal. Whenever we've interviewed people, they're like, so what are your options for that? Because these brand new doctors are, they've got $200,000 of loans that they're trying to pay back and buy a house, have babies and build a family and start a practice. And it's insurmountable for some of them. So they go to places where those reimbursement options exist so that they can pay that off and then get going in their career.
Carolyn, you had one more question?
Yeah, well, more of a comment. After listening to you, Dr. Hebard, when you talked at the public health district monthly meeting, I think a couple months ago, and said some of these same things, particularly about your Medicaid reimbursement. I contacted Senator Rolfus. Do you live in the 23rd, by the way? LD?
Yes.
Okay. Well, anyway, so I contacted her. I said, there's an issue about Medicaid reimbursement. And I didn't specifically realize that maybe your Medicaid reimbursement rate with your specialty is different than Medicaid reimbursement rates in others, because she was a little offended because she being the chair of the Ways and Means was saying, well, we're one of the highest Medicaid reimbursement, have one of the highest Medicaid reimbursements in the country as Washington. And
well, actually, she's correct. Like if you look at Medicaid reimbursements for Washington State, what I get paid for, and pregnancy care is so weird too. Like we get paid as a global fee. So we get paid for all of the antepartum care, the delivery procedure, and the postpartum care as a unit. And in our state, we actually are on the upper end of normal for nationwide Medicare. So she's quite right about that. I would say we get from Medicare, Medicaid around $2,500 for that whole pregnancy service. Whereas if you go to Texas, you probably get $1,100. And that's just absurd. I mean, the amount of time that we spend with all of our antepartum visits and the level of complicated pregnancies and complicated people that we have in a somewhat socioeconomically depressed area, and the delivery itself. I mean, my God, the anesthesia provider gets paid $2,000 for an epidural. And I get paid $2,500 to take care of the whole thing.
Right.
So
So,
yeah, $2,500 is definitely above the national norm. She's 100% correct with that. But I don't think that reflects what we do or what we're worth, or to be able to, again, how do you do that? How do you function on a practice basis?
right. So does the state have the ability to increase your particular specialty Medicaid reimbursement? And is that something that we should contact Senator Rolfus about?
Oh, I think absolutely you should contact her. Whether that is possible without changing legislation, I don't know, but presumably she would be able to figure that out. That was one of my inquiries when I was reaching out to that. I'm again blanking on her name. If you look at their flow chart for who's what on the state healthcare advisory committee, there is a Medicaid supervisor who basically, or director who does that kind of stuff. And it got the same kind of response. Yes, that's really interesting. I'll look into it. I mean, these are busy people. I get it. But that would be something that potentially a group like yours could reach out and try to have more active conversation.
Okay, so do you mind if I reach out and referencing you to Senator?
Oh, please. Yes, please do.
And would you like to have a meeting with her?
Yeah, absolutely.
Okay. I'll set it up.
Okay. Yeah.
Yeah, and I want to just add to that. For my husband's entire professional career, it's common knowledge that primary care physicians, medical care is reimbursed at a lot less than surgical care.
Mm-hmm.
And here we have a surgical subspecialty that is treated as a medical reimbursement rate. Now, I understand, I get it. I understand that pediatricians and family practice and other internal medicine primary care providers probably have some lower costs. They definitely have lower cost malpractice insurance. I can guarantee you that. But I think one of the really interesting things that so few people understand about this is how this system is set up in such a way that we don't pay for the kind of care that would prevent tons of things. Prenatal care prevents, I can't tell you all the things it prevents. A lot of things my husband had to deal with, a neonatologist. So I think the reality is that it's that big picture view of, in general, how we choose to reimburse care. Medicaid is a subset of the system. And she's right. Kathy's 100% right. The anesthesiologist who is there for one epidural every whatever, so many OB patients, they get more than you get, or almost as much as you get for the whole of that individual during their pregnancy. And that's more than 9 months, as most people don't realize. So I find that really a systemic thing that the league can work on. And in particular, there are some options in Washington state. The choice to be made is, if you take money from your Medicare allotment, you can add to it at the state level. That is an option. And we do that here in Washington state. We were one of the first to provide children's health insurance at a sensible rate. So Washington state has been at the forefront of a lot of things, but there are some big areas like OBGYN in particular, but also a few others that are really undervalued in the economic system.
And that's a national thing. And I think that's based in, social discrimination. I mean, I don't think women have been truly valued in terms of our contributions and our worth. Definitely on the short end of the stick with that. And I think the payments are reflective of that.
Mhm.
And again, I have, colleagues all across the country, and it is not unique to this area. And in some places it's a whole lot worse. So I do think that Washington it remains progressive, even in this sector, but it's far behind, I think, what's a reasonable, equitable way to pay us. And I think that, goes back to the universal healthcare thing. If you had that, you could have equality, you could have appropriate distribution, you could have, tort protection for people that would make this job a more attractive job.
Mhm. Well, thank you very much for answering all of our questions. And I hope we can continue our conversation, not just as Carolyn has suggested, directly with one of our representatives.
Yeah, please. Thank you for
happy.
I really appreciate your interest. And I do think that it's going to be a grassroots thing, because, one lone voice shouting into the void is not going to get us very many places. So,
No, thank you.
all right. Thank you very much.
Mhm.